We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to today's episode of A Pinch of Salt proposed by the ERA. I am George Kosmatakis, a nephrologist from France, and today's podcast concerns the adaptations of anti-rejection treatment in a failing renal graft. The patients with failing renal grafts is a very sensible group, accumulating the risk factors associated with renal failure, as well as the effects of a long period of immunosuppression. Their handling is delicate, especially in what concerns the anti-rejection strategy. Our today's host is Professor Cristophe Mariat, head of the Nephrology, Dialysis and Renal Transplantation Department in Saint-Étienne, France, chair of the ERA DESCaRTES Working Group, and president-elect of the French-speaking Society of Nephrology, Dialysis and Transplantation. Professor Mariat has also authored or co-authored more than 200 peer-reviewed articles. Professor, welcome to the Pinch of Salt.
Thank you for your invitation.
Thank you. So I will start straight away with the first question, which is always evidently naive, but not too much. What is nowadays the actuarial survival of renal grafts, and has that changed over the time?
Well, George, to answer your question, we have first to acknowledge differences across countries and even more importantly, across continents. If we focus on Europe, even though there is substantial heterogeneity between European countries, we have data from the ERA registry indicating a 5 years post-transplant graft survival for the recent era around 75 to 80%, depending on the nature of the donor, deceased donor versus living donor. I would also mention the French registry from the Agence de la Biomédecine, keeping in mind the particularities of the French transplant program, the main aspect being a relatively small proportion of living donors, around 15% of living kidney donors in France. From the French data, the actuarial 10 years graft survival within the period 2007-2022 is 57%, with a median survival time of 140 months. More interestingly, when you look at the trends, you see that graft survival is kind of stabilizing at the same level over the next decade. And basically, during the most recent decade, we even see a kind of decline in the graft survival. The main reason to explain this situation has to do with the characteristic of both donors and recipients. We tend to be older with more comorbidities in the most recent period. The consequence of this is that you have to take care more and more patients with failing graft, with a significant proportion of them being very vulnerable. So we can say that dealing with transplant patients returning to dialysis is an important issue for the nephrology community.
Right. So from your answer, I understand that this podcast is it was a good idea because we have patients that are more fragile. We have also the kidneys, the grafts are becoming of a lesser, if we may say, quality, and therefore we have a bigger population with a failing kidney. How do you deal with the anti-rejection treatment in a failing kidney? Which are the objectives?
Well, studies they demonstrate that for transplant recipients who return to dialysis, there are increased risk of cardiovascular complication, infection, and death compared with incident dialysis patients without a transplant. One explanation for this observation is the continued use of immunosuppressive medication, which increase the risk of infection and lead to an adverse cardiovascular profile. In this respect, early immunosuppression withdrawal seems to be logical. On the other hand, the ongoing use of immunosuppressive medication may alleviate the consequences of chronic inflammation of the allograft, preserve residual renal function, and reduce allosensitization to improve retransplant opportunities. Several retrospective studies have demonstrated a marked increase in anti-HLA antibody formation in prior transplant recipients who undergo immunosuppression reduction, and this negatively impacts access to retransplantation. Importantly, anti-HLA antibody formation during immunosuppression weaning is not just limited to donor-specific antibodies. Immunosuppression withdrawal in patients with allograft failure also leads to the production of anti-HLA antibody directed against a broad range of anti-HLA antigens, hence further reducing the potential donor pool available for the patient. So I would say that the real question when it comes to immunosuppression reduction is who to consider. Basically, we have to consider the individual's clinical status and potential for retransplantation. Individuals for whom transplantation is unlikely to occur or with life-threatening complication of immunosuppression should undergo reduction in immunosuppression regardless of the risk of rejection and sensitization. Withdrawing immunosuppression on dialysis may reduce the mortality of patients awaiting transplantation, suggesting that continued immunosuppression to avoid sensitization must be balanced against the risk to the patient. In individuals without complication from immunosuppression and who are expected to undergo retransplantation soon after experiencing graft failure, continuing immunosuppression, especially CNIs, to avoid allograft nephrectomy is reasonable. And allograft nephrectomy is really a big issue. Indeed, one commonly reported disadvantage of allograft nephrectomy is related to the formation of anti-HLA antibody and the activation of the immune system. There is ample literature suggesting that late allograft nephrectomy leads to an increase in donor-specific antibodies and non-donor-specific antibodies. It is speculated that a retained allograft may serve as an antibody sponge. This theory proposed that preformed anti-HLA antibody are sequestered in the failed allograft and that allograft nephrectomy results in the release of this antibody into the circulation. In addition, anti-HLA antibodies have been found at very high level in the eluate extracted from the allograft, but not to a similar degree in the serum. And moreover, the rapid formation of new donor-specific antibody following allograft nephrectomy is also suggestive that the antibody were preformed. Synergy certainly exists between immunosuppression and allograft nephrectomy, contributing to allosensitization. This was seen in a small study by Arnaud Delbello from Toulouse, measuring patient DSA level using Luminex technology. Immunosuppression cessation led to increased DSA level in both allograft nephropathy and non-allograft nephrectomy patients, but the increase was more pronounced in allograft nephrectomy patients. Altogether, those data support that the decision to continue, reduce, or withdraw immunosuppression in a patient with a failed kidney allograft must be individualized. It is currently recommended that patients with an anticipated wait for retransplantation of over 1 year be considered for reduction in immunosuppression, as the risk of ongoing immunosuppression are felt to outweigh the benefits of avoiding sensitization for a transplant that is not to occur for some time.
Right. So this is a balancing act actually, and you have to take into consideration the risks and the benefits, and of course, whether the patient is retransplantable or not. And we should avoid at any price the allograft nephrectomy. So practically, what about the anti-rejection therapy after the initiation of dialysis? How can I am a clinician? How can I proceed?
Well, George, unfortunately, we have very limited data in the literature to guide us. This being said, Discontinuation of the anti-metabolite is a reasonable first step in a kidney transplant recipient with a failed allograft. Whether or not this should occur at the time of renal replacement therapy is unclear. A slow weaning of steroids and or CNIs over 3 months is recommended over a more rapid taper. Whether this should be done in sequence or in tandem is unknown. Current guidelines recommend that CNIs are reduced by 50% every 3 months, with consideration to stop prednisone at any time. This recommendation seems reasonable given the importance of CNIs in preventing DSA formation and the effect of prednisone on cardiovascular risk. More studies are needed to determine the order and timing of immunosuppression withdrawal and the temporal effect on allosensitization. In addition, surveillance anti-HLA antibody monitoring during immunosuppression weaning may enable the early detection of allosensitization and provide a signal to maintain immunosuppression in a clinically stable patient with allograft failure. However, the logistics of testing remain very challenging. Often the patient with a failed allograft is no longer under the care of the transplant center, and the transplant team may be unaware of changes in immunosuppression. Often these changes are performed under the care of the local treating nephrologist. An additional challenge is that once patients become broadly sensitized, treatment to desensitized patients are ineffective. Altogether, this consideration call for prospective randomized controlled trials addressing the benefit, the nature, and the monitoring of immunosuppression withdrawal in patients with failing graft.
Right. So we don't know exactly how can we do the tapering of the CNIs. It is very important to monitor the HLA antibodies regularly in order to adapt our anti-rejection strategy. And we desperately need more trials in order to have the best optimal protocols for this stage of patients. So things are still rolling. Thank you very much, Christophe. And now I will go on to the most get to know you personal question, which is whether if you were in a desert islands, what book, 2 songs, and luxury item would you take with you?
Well, very difficult, difficult question. As for
everybody says that this is the most difficult one.
As for the book, I would say Victor Hugo, Les Misérables.
Les Misérables, okay.
Yes, which is a very famous famous book. But I would insist to read it in its extended version, meaning more than 2,000 pages. This book is a mix between a history book and a novel. It's about resilience, injustice, hope, and love. And at the very end of the story, everything is in its right place, something that we are certainly missing a lot nowadays. As for the song, the first song, I would say Let Down from Radiohead. This song is like a tribute to David Leitch. When you carefully listen to this song, you are not in a position to know whether it's a happy song or a sad song, and actually everyone can have his own interpretation, like when you watch a movie of David Leitch. And the second song is a song from a famous French singer called Barbara, and I love her song Göttingen. And this song is about reconciliation, forgiveness, and clearly embodies what should the European spirit be. This song was actually part of the shortlist to be the official European anthem, but ultimately it was not selected. And there is a French and a German version of this song, and it's just wonderful. And finally, as for the luxury item, I would say my wedding ring.
Oh, wonderful, wonderful. You know, at the end of the year, we are doing a playlist of all the choices of our guests, and I heard the last year's playlist. It was very variable, and I loved it. So you chose two wonderful
Very good
songs.
idea.
Yeah, it's available on YouTube if you want. So thank you so much, Christophe, for this exchange. Dear colleagues, I hope you enjoyed the discussion with an eminent specialist on this very sensitive matter. The treatment options for this group of patients is adaptive and redefined. More things to come. We need desperately more studies. Please stay with us for more podcasts in all digital platforms. Thank you very much.